prominent. Did you go up, sir? So you want to see if one side is higher than the other, and you want to see if one side is more prominent or posterior versus the other. Of course, we'll mention eventually how when it rotates, it doesn't just rotate around the x-axis, but like everything else in the spine, it translates. As it rotates posteriorly, there's a little bit of a posterior translation along the z-axis, so it'll become a little prominent. And many patients will say, it feels like the bone is sticking out. And that's why they feel that, because it has rotated and it has translated back a bit. These are all very small movements. Okay, so crest, PSIS on the bottom, greater trochanters come in, and then just bring the patient side to side, get on top of the trochanters, and look for any asymmetry in height, any disparity there from one side to the other. Turn around, ASIS, come in there, get on the bottom. Make sure you're consistent. You don't want to be on top one time, in the middle on another, and then on the bottom on another, because that will throw off your findings. So find the ASISs and try to come in on the same exact spot. Most people find the inferior aspect of the most prominent area to be the most consistent, and then compare left to right. And what are your results? Your results can be symmetrical, totally the same, which is normal, or asymmetrical. And then you have, with ASIS and PSIS, you have up versus down, prominent versus deep, I guess you could say. Anterior, for this, prominent, posterior, deep. For PSIS, posterior would be prominent, anterior would be deep. Iliac crest, just look at the height. Greater trochanters, just look at the height. Okay? And have a seat. Okay. Iliac crest. Height comparison, sit up straight. PSIS, follow the crest down. Inferior aspect, compare the height. Sit up straight. Okay, that was too high. Sit up straight. Here we are. So compare the height and the prominence. And I'll come around here. ASIS. Height and prominence. And let's have you on your back. Now, you can get some false readings if the pelvis is not centered, if it's not balanced. You have a lot of asymmetric forces. You have the influence of the adductors pulling it down on one side. Actually, we talked about that. The abductors can pull it down. The adductors can actually raise it up a little bit on that side if it's tight, because the pelvis will do that to accommodate that. You've got the influence of the rotators of the hip, the rotators of the trunks. You've got lots of forces coming from above and from below, influencing the alignment of the bony pelvis. You want to try to balance things out as best you can. This is what most people do to balance it. Bend your knees, feet flat, lift up, do a bridge, bridge up and down, and then I extend and give it a little traction and drop. Some people will bend your knees, bring your knees to chest, you can do it that way, and a little tug. Most people use the bridge. Come in, ASIS, check differences in height, posterior, anterior, and I could check. I'm going to have him find your pubic symphysis for me with your hand. If you come in from below, you may make a mistake, and it's uncomfortable. So I come in, he finds it, I go right over his hand, I'm on the pubic tubercle, I compare right to left, height and prominence. Turn over on your stomach. Balancing is a little difficult here. I'll just pull on his legs a little bit. Iliac crest, which I should have done sitting. I don't know if I did. Check the crest. Come down. PSISs. Check. And we already did ASIS, ischio-2. Thank you. Come in here. Make sure you get permission from the patient. You're in the buttock area. You're looking for ischio-2 coming up. Hamstrings attaching there, and compare. Primarily differences in height. Okay. So these are the bony landmarks under A, asymmetry, for innominate on sacrum dysfunction, as well as symphyseal shear, up shear, down shear of the pubic symphysis. Eventually, you're going to get into a manual 3. You're going to palpate the base of the sacrum. You're going to make an A to P comparison. You're going to go down to the inferior lateral angle of the sacrum. You're going to make a height comparison as well as an anterior and posterior comparison. So you've got 2 more landmarks to learn later. Sacral basis and the inferior lateral angles, or the ILAs. And then with the sacrum, because it's more a function of the spine than the innominate is more a function of the lower extremities. The sacrum being very much affected by what's happening in the lumbar spine and vice versa. We're going to have to test the sacrum in 3 positions. That gets real interesting. We test it in neutral, we test it in extension, prone on elbows, and we test it in sitting. And then we collect all our data and we come up with what's happening at the sacrum, SI, what's happening at the innominate, IS, what's happening at the pubic symphysis. And that's the treatment of the pelvic girdle. And then you've got hip issues to think about. You've got lumbar spine issues, and it gets pretty interesting. Anyway, we'll slow it down and take one area at a time. All right, thanks, Jed. So that's under A. So after you do your postural assessment, you're going to specifically start to look at bony landmarks to see if you have malalignment. Now that malalignment may mean something, it may mean nothing. Because the osteopaths have said for over 100 years, if it's out, but it moves, let it be. Leave it alone. So we're not terribly concerned about malalignment as long as that malalignment is functional. When that malalignment becomes stiff and limited, that becomes an issue. And that's what has distinguished traditional osteopathy from traditional chiropractic. But now chiropractors are looking more at motion. Over the past 20 years, their paradigm has changed into the realm of motion and fixation, which is good. So alignment's important, but only in conjunction with motion and what's happening in the connective tissues and muscles. All right, so let's get started. Let's look at